But over here, for simplicity, I am discussing only two major patterns. One is the linear pattern, one is the granular pattern. Remember, the granular pattern again can be subdivided as fine granular or coarse granular. And then there is another pattern where there is a diffuse smudgy pattern as well. So there are three important patterns in immunofluorescence. One is the linear pattern, one is the granular pattern, one is the diffuse smudgy pattern. So this, as you can see, this is the renal core biopsy. This is one core, and you can see certain bulges over here. And these bulges are basically signifying the presence of a glomeruli. So what is the adequacy? At least two core, each of at least 1 centimeter in length and diameter of 0.5 to 1 mm, or diffuse proliferative glomerulonephritis. So you can see over here there is increased marked hypercellularity, there is an increase in the number of mesangial as well as endothelial cells as well, and lots of inflammatory cells we can see. This is a neutrophil. Myself, Dr. JIBRAN Ahmed, presents to you Simply Pathology, and today we are back with a very important session. Today we are going to discuss about the renal biopsy. Renal biopsy is a very important topic from exam point of view because it is very commonly asked as a long answer question in your exam. Now it is a very difficult and very large topic. So in this topic, in this session, what we have tried is that we want to discuss this topic in a very concise manner and in a easily reproducible manner, so that you can easily understand also and you can reproduce the same in your exams. Okay. Not only that, lots of practical aspects are also discussed in this particular video. So please pay a lot of attention. So what are the things that we are going to discuss in today's topic of discussion? We are going to see the basics of renal biopsy, followed by the indications, contraindications, the prerequisites, the complications, and the procedure in details we are going to discuss. Apart from that, we are also going to discuss how do you handle after you have procured the biopsy, how do you handle the biopsy? Okay, handle the biopsy, how do you divide the biopsy for light microscopy or immunofluorescence or electron microscopy. Okay, what are the different fixatives used, what are the special stains that we are using, okay, while we are evaluating a renal biopsy. After that, we are also going to discuss in details about the individual processes. Okay, so we are going to systematically evaluate the glomerulus, followed by the tubules, followed by the interstitium, followed by the blood vessels. Now in this topic, okay, we are mainly going to discuss in details about the evaluation of the glomerulus, okay, and we are going to in very short, okay, discuss what are the structures, what are the things to evaluate while you are evaluating the remaining structures. So under the glomerular heading, we are going to discuss in details the light microscopic features, the immunofluorescence features, and the electron microscopic features in detail. So please pay a lot of attention, okay, till the end of the lecture. So without wasting any time, let us begin. So first, what is renal biopsy? It refers to obtaining a small piece of kidney tissue for microscopic examination. So what is it used for? It is used for either establishing a diagnosis, or to assess the severity and activity of a disease, or to assess the prognosis, or to plan treatment and monitor response, and not only that, to also diagnose any kidney transplant dysfunction and to evaluate the different causes of kidney transplant dysfunction. Now always remember that renal biopsy is associated with a risk of procedure related morbidity and rarely even mortality. Therefore, before you perform a renal biopsy, the risk of the procedure versus the benefits of histological examination should be evaluated for every patient. Now, the accurate interpretation of renal biopsy requires a detailed knowledge of the normal structure and function of the kidney. Now, we have already discussed in details about the normal structure of the and function of the kidney, okay, in our previous lecture. So, please refer to those lectures, okay. And not only that, we need to have a basic understanding of the clinical, morphologic, and histopathological aspects of the renal disease that we are suspecting as well. So to evaluate a kidney biopsy, a pathologist should also correlate with the clinical and laboratory information with light microscopic, immunofluorescence, and ultrastructural findings. Okay. So what are the indications of carrying out a renal biopsy? The first indication is nephrotic syndrome in adults with evidence of systemic disease, which also happens to be the most common indication, or nephrotic syndrome in children which is not responding to corticosteroids, or nephrotic syndrome in infants, that is congenital nephrotic syndrome. Acute nephritic syndrome for differential diagnosis, unexplained chronic kidney disease with near normal kidney dimensions on imaging, patients with asymptomatic hematuria when other diagnostic test fails to identify the urological source of bleeding, or kidney biopsy is needed in patients who are having persistent non-urologic microscopic hematuria with proteinuria and or kidney insufficiency, or patients who are having isolated non-nephrotic range proteinuria in the range of 1 to 3 grams per 24 hours with renal impairment, or there's an impaired function of renal graft. So recipients of kidney transplant who are presenting with proteinuria, hematuria or transplant dysfunction, to differentiate between the various forms of rejection and the various causes of rejection. Involvement of kidney in systemic diseases like SLE or amyloidosis, or in conditions of acute kidney injury, the kidney biopsy is indicated if a patient with acute kidney injury is not responding to therapy. Okay, pre-kidney disease, acute tubular necrosis and urinary obstruction should be excluded since the diagnosis is apparent from clinical history, and these conditions do not require renal biopsy evaluation. Now, coming to the contraindications of taking a renal biopsy, the number one contraindication is uncontrolled severe hypertension, a patient suffering from a hemorrhagic diastasis or a bleeding tendency, or if that is the only, or the person is having a solitary kidney. Okay, so because the procedure becomes little bit blind, although you are doing under imaging guidance, but still you might damage the kidney unknowingly. So that is why if you have a single kidney, okay, so you should not carry out. It is a contraindicated if there is a solitary kidney. If there is a renal neoplasm, so the basic worry or the basic tension is that if you carry out a, if you introduce a needle through the renal neoplasm, okay, so you might spread, okay, so you might spread the malignant cells. So if you are suspecting a renal neoplasm, so renal biopsy is contraindicated so as to avoid the spread of malignant cells along the needle tract. If there is presence of large and multiple renal cysts, or you have a small shrunken kidney less than 9 centimeters in size, because in that case there is an increased risk of hemorrhage and low biopsy yield. Skin infection over the biopsy site, acute urinary tract infection like pyelonephritis, sepsis or perinephric abscess, urinary tract obstruction, non-cooperative patient, or in case of hydronephrosis. So these are the contraindications for carrying out a renal biopsy. Next, we are going to discuss about what is the pre-biopsy workup and what are the complications that you face. So what are the pre-kidney biopsy patient workup? It includes, so what are the things that you have to do before or prior to taking a renal biopsy? Number one, you have to do the imaging to document the presence of two kidneys which are having a normal size. Blood pressure should be less than 160 by 90 millimeters of mercury. You have to do the coagulation profile as in the BT-CT, platelet count, PT, APTT, all should be within the normal range. You take the drug history. If any history of NSAIDs or anti-inflammatory drugs, then you have to postpone the procedure for at least 7 days. For at least 7 days, you have to postpone the procedure. Urine culture you should carry out to rule out any infection, so it should be completely sterile. Carry out the blood grouping and the cross matching of the patient. Okay. In case there is bleeding and the patient requires blood. So what are the complications that happens? Number one is hemorrhage. As the renal cortex is highly vascular, major risk of bleeding in the form of hematuria or perinephric hematoma is there. Severe bleeding may occasionally necessitate the blood transfusion and rarely the removal of the kidney. AV fistula, another complication. Infections, accidental biopsy of another organ or perforation of viscus like the liver, spleen, pancreas, adrenals, intestine or gallbladder, and very rarely it can lead to death as well. So how do you carry out the procedure? So it is very easy. As you can see, the most commonly used method is the percutaneous renal biopsy, as it is shown over here in this particular figure, under imaging guidance. So under the guidance right now they are using the USG guidance. They are carrying out this percutaneous renal biopsy. What are the other methods? Other methods include transvenous renal biopsy, open biopsy or laparoscopic biopsy. So basically in conditions where there are relative contraindications like a bleeding tendency is there or a patient is highly obese, you can go for this transvenous approach. Open biopsies are usually more sure shot. So in case the patient is having a solitary kidney and yet it is very important to carry out the biopsy, you have to go for the open biopsy. And laparoscopic biopsy, again, it is just the advantages. So you will have lesser, exposure in case of laparoscopic compared to the open biopsy. Okay. So very important thing, what are the important steps that you have to understand? The patient's informed consent. Informed consent means that you have to explain the procedure in details and what are the risks and what are the complications, okay? What are the complications that can happen as well? So you have to explain everything to the patient. USG or CT scan is done to document the location and the size of the kidneys. The patient should have 2 kidneys of normal size and shape. Blood pressure should be less than 160 by 90 millimeters mercury. BTCT, PT, platelet time, PT, APTT, all should be normal. Blood sample should be drawn for blood grouping and cross matching as blood transfusion might be needed, and the urine culture should be completely sterile. Systemic anticoagulants and antiplatelets like aspirin and NSAIDs should be discontinued at least 7 days before the biopsy. Most renal biopsies are done by either the percutaneous route by using a cutting needle or by direct exposure of the kidney, that is open surgery. Often a wet sampling of the outer cortex is taken. Now, most centers are using 16 to 18 gauge needles for adults and 18 gauge needles for children less than 8 years of age. Now, usually the most commonly used position is if you are taking the biopsy from the native kidneys, then the prone position. Else you have to, in case of a transplanted kidney, you do it in a supine position. The patient has to be sedated before the procedure. The patient is lying in the prone position and the lower pole of the kidney is identified with the ultrasound and procedure is carried out under real-time imaging. The skin over the selected site is disinfected and local anesthesia infiltrated. A small skin incision is given with a scalpel to insert the biopsy needle. Location of the kidney is done, okay, with a fine bore 21 gauge lumbar puncture needle. So with that you are localizing the needle, okay. A local anesthetic is infiltrated down to the renal capsule. After you localize, a true cut biopsy needle or spring loaded biopsy gun is inserted under USG guidance and advanced down to the lower pole. Biopsy is usually obtained from lateral border of the lower pole. This is the site of biopsy. The patient should hold his or her breath in full inspiration during biopsy. After obtaining the biopsy and removal of the needle, the patient is allowed to breathe normally. Usually 2 to 3 cores are considered as adequate. The biopsy should be placed in a drop of saline and examined under a dissecting microscope for adequacy. Patient is turned to supine position after the procedure. The vitals are monitored and urine should be monitored at regular intervals. Patient is usually kept in hospital for 24 hours for observation. Now, handling of the renal biopsy. How do you handle the renal biopsy? So, over here after the procedure, this is the true cut needle. You can see a core of renal biopsy. So, a core of renal tissue is demonstrated in the sampling notch of the biopsy needle, as we can appreciate over here. Now, the specimen after you have taken the biopsy. Now, remember the adequacy. What is the adequacy? Remember that you should obtain at least 2 cores and at least the length should be 1 centimeter and the thickness should be in between 0.5 to 1 mm at least. This is the minimum required thickness, okay, that should be there. And remember, while you are examining, minimum, at least 5 to 10 glomeruli should be present while you are examining, okay, while you are examining the particular renal biopsy section. This is the minimum required of glomerulus for examining the renal biopsy. So the specimen should be divided for light microscopy, immunofluorescence and electron microscopy. Ideally 2 cores, as I told you, 2 biopsy cores should be obtained when a needle biopsy is performed. From the first core, 2 or more samples measuring 0.5 to 1 mm in thickness are taken from each end with a fresh razor or scalpel blade and placed in a cold solution of 2% glutaraldehyde for electron microscopy study. So if this is the first core, so 0.5 to 1 mm at both the ends, this part and this part, they should be reserved for electron microscopy. And what is the fixative which is used for electron microscopy study? 2% glutaraldehyde is used. This remaining part is kept in saline and this part which is kept in saline is to be used for light microscopy purpose, okay, for light microscopy. Now the second biopsy or the second core, if it is adequate, again the same thing has to be done. From both the ends you have to take 0.5 to 1 mm thickness, okay, you have to remove from electron microscopy purpose, and the remaining that you are having is to be used for immunofluorescence. And for immunofluorescence you directly, without using a fixative, you are giving it directly for frozen section. So if the second core is adequate, the sample should also be taken from each end for electron microscopy, while the remainder is snap frozen in liquid nitrogen, okay, for immunofluorescence. Okay, so remember this point. I am going to repeat once again how you divide. and this rule or this guideline is given in Ackerman. Okay, in Ackerman they are using this particular guideline. So as a pathologist, if I am going to write an answer, I am going to stick to what is given in Ackerman, and I am also writing the source. So what is the source? That from the first core, both the ends electron microscopy, from the one which is remaining light microscopy. From the second core, if you see, from the second core, from both the ends should be used for electron microscopy, and basically the first end that is there, the remaining part should be used for immunofluorescence. Okay. Now for light microscopy we are using 10% formaldehyde as a fixative. For electron microscopy we are using 2% glutaraldehyde, and for immunofluorescence no such fixative is required. Directly the sample is snap frozen in liquid nitrogen, okay, for immunofluorescence study. So this is how you are dividing. Okay, this is how you divide. Okay, so for light microscopy, the tissue that was placed in saline, as I told you, this one should be transferred to a fixative, most commonly being 10% buffered formalin. So I hope you have understood how we are dividing, okay, for examination. Now remember, now for example, you have carried out the procedure with with a lot of difficulty, and because of any reason you have obtained just a single core. So how you should divide? Again, over here you should divide from the end. Both the ends should be divided for electron microscopic study, whereas this remaining part is divided again for light microscopy and for immunofluorescence. This is how you have to divide in case only one core is available. Now suppose if only a very small core is there, okay, like 0.5 or 0.6 centimeters in maximum length. In that situation, you do not need to give for light microscopy. Just divide it from middle. One part should be for immunofluorescence, another part should be for electron microscopy. Okay, why is it so? Because most of the light microscopic information can be obtained from the study of semi-thin sections of plastic embedded tissue which is processed for electron microscopy. So in the process of in the processing of the electron microscopy, semi-thin sections of plastic embedded tissue can also be used for getting light microscopy information. Okay, so if it is very small, okay, you just divide it between immunofluorescence and electron microscopic study. Remember, all this kind of division, these are transverse sections. Okay, you never divide it like so. For example, if this is a particular core, okay, you do not divide it longitudinally like this. So longitudinal division of the cores should be avoided. Now the triaging of the biopsy sample should ideally ensure that all three portions are including the cortex. Now remember, on gross examination of the cores under dissecting microscope or a magnifying device, glomeruli in well-preserved cortex appears as pale or congested bulges. However, this may not be evident when the cores with sclerotic glomeruli or fibrotic interstitium are examined. So very importantly, even if you examine the particular core, okay, if you examine them grossly, you can see certain pale or congested bulges. Those are actually signifying the glomerulus, and adequate number of glomerulus is minimum 5 to 10 glomerulus should be there. Okay, so this, as you can see, this is the renal core biopsy. This is one core, and you can see certain bulges over here, and these bulges are basically signifying the presence of a glomeruli. So what is the adequacy? At least two core, each of at least 1 centimeter in length and diameter of 0.5 to 1 mm. Okay, some of the some texts are also saying it should be between 1 to 1.2 mm as well. Okay, so it varies between different institutes. So a renal biopsy must contain glomeruli to be considered adequate, but there is a disagreement over the number of glomeruli required to make a diagnosis. So for example, in disorders characterized by epithelial proliferation like irregular or crescentic proliferation, the assessment should be based on a minimum of 10 glomeruli. Whereas in diffuse lesions, the identification of specific features in a single glomerulus may be sufficient for diagnosis. A good guideline to follow is that at least 5 to 10 glomeruli should be examined to properly assess the extent of the disease. Okay, so this is the adequacy of the renal biopsy. Now, I just wanted to show you in different kinds of American Society of Nephrology or in different boards, they also have one other way of dividing. What I have discussed is from a pathological point of view. From a nephrology society, okay, or from the from the medicine people, they have some other idea of dividing. okay, for examination. So even if some examiner is saying this is also right. So there is no generalized acceptance to the way you have to divide the core. So over here also, what they have done from the first core, again they have divided the ends for electron microscopy, okay, and they have divided one part for light microscopy and another part for immunofluorescence. Okay, now this part is the cortex, this part is the cortex part, and this is the medulla part of the core. Now from the second core, the same thing is done for electron microscopy, but what they have done, the portion that is closer to the medulla is now opted for light microscopy from the second core, whereas the portion okay, which is near the cortex is now preferred for immunofluorescence. So this is how they are doing. Okay, so this is one other way of dividing the renal biopsy core as well. Okay, now kidney biopsy, they can be divided into three parts as we have already discussed, for light microscopic evaluation, for immunofluorescence, and for electron microscopy. Now for light microscopy, renal biopsy is routinely fixed in NBF, 10% neutral buffered formaldehyde, for light microscopic evaluation. Okay, and after you fix, so what are the different stains? So routinely you are doing the H&E stain, hematoxylin and eosin, for the generalized architecture of the kidney and to assess the cellularity. Then the most useful stain in kidney biopsies is the PAS stain, which is done routinely so as to highlight the basement membrane and connective tissue matrix, so as to evaluate whether there is basement membrane thickening, whether there is connective tissue matrix deposition or no, okay, or any kind of hyalinization is there or no. So we are doing the PAS. Other stain is done, that is the trichome stain. Again they are staining the basement membrane and the mesengium dark blue and the interstitial collagen pale blue. Silver stain again done where the basement membrane and the mesangial matrix is stained black, and Congo red done for amyloid, for detection of the amyloid. So these are some of the special stains and the routine stains that is basically used for evaluation of renal biopsy routinely. Now electron microscopy, for electron microscopy the tissue is fixed in 2% glutaraldehyde as we have already seen prior, and for IHC as we know, and for immunofluorescence basically no this thing is done, but for direct immunohistochemistry if you want to carry out, you can actually use the paraffin embedded block as well for IHC, but for immunofluorescence again you do not require fixation, and over here directly the tissue is snap frozen. And again antibodies that are most commonly used are those against immunoglobulin IgG, IgA, IgM, kappa, lambda, C1q, C1, C3, C4, fibrinogen or fibrin. So over here we are employing antibodies to detect, okay, other antibodies, okay, which are deposited in the kidney, or their immune complexes which are deposited. Okay, this is the reason why we are using immunofluorescence, and looking at the immunofluorescence patterns we can correlate with the diagnosis. So these are the special stains for renal biopsy. As you can see, this is the H&E stain. Okay, over here we have used the PAS stain, number 2, number 3 the trichome stain, wherein the basement membrane and the collagen is stained blue, and here is the silver stain wherein the basement membrane and the mesangial matrix is stained black in color. Okay, as you can appreciate over here. Now the renal biopsy evaluation, it needs evaluation of the glomerulus as well as the tubules, interstitium and vessels. So over here in this particular session, we are mainly going to concentrate on evaluation of the glomerulus, whereas we are going to see what are the structures evaluated while evaluating the tubules, interstitium and vessels. Maybe in the future, we are going to discuss how to evaluate these structures in details. But for today's topic of discussion, okay, and for exam purpose, okay, it is not possible to include every other things in details, like the tubules, interstitium and vessels in details. So maybe in the future I will make a part 2 of this renal biopsy evaluation, wherein I am going to discuss the evaluation of tubules, interstitium and vessels in details. But as of now, for your exam purpose, I am mainly going to discuss the glomerulus. So what are the patterns of glomerular injury by light microscopy? So I have divided them in the light microscopic patterns into 7 or 8 types. Okay, so we are going to see each one of them. So as we have already seen, 10% neutral formalin provides good morphological details while also preserving the sample for future immunohistochemical studies or immunofluorescence microscopy on paraffin embedded tissues if needed. A panel of stains like H&E, PAS, silver stain or trichome stains are recommended for routine evaluation of renal biopsies, but from practical point of view, as I told you, PAS is most useful, easiest to perform and can also provide most of the information. It is recommended that the biopsy cores be serially sectioned 2 to 3 micrometer thick, and that 3 to 4 tissue sections are placed on each slide. At regular intervals, one slide is stained with H&E one with PAS, one with trichome and another with silver stain. By following the procedure, maximum number of glomeruli can be examined. The remaining unstained slides are saved in case special stains or IHC stains are needed. Okay. Now coming to the patterns. Now the first pattern under light microscopy wherein no abnormality is seen by light microscopy evaluation. So in this case, it suggests either you are dealing with no disease at all, so it is a normal glomerulus, or you are dealing with a diseased glomerulus showing no light microscopy features like MCD, minimal change disease. So only change that is seen in MCD can be detected by electron microscopy wherein there is effacement of the food process, or in mild early glomerular disease. Okay, for example, class 1 lupus nephritis or IgA nephropathy or Alport syndrome. Okay, so mild or very early glomerular disorder or disease, you will see that there is no abnormality detected under light microscopy, as we can appreciate over here. Everything is normal over here. There is no thickening of the basement membrane. There is no mesangial deposition. Everything looks normal, completely normal. Second is conditions where you develop very thick capillary wall without any kind of capillary hypercellularity or any mesangial expansion. So there is no hypercellularity, no mesangial expansion as well. So what are these conditions? Membranous glomerulopathy, both primary and secondary, or thrombotic microangiopathy with expanded subendothelial zone, or preeclampsia with endothelial swelling. So these are the conditions where you only have a thick capillary wall without any hypercellularity or mesangial expansion. Let me show you with the help of diagram. So as you can appreciate over here, the characteristic feature on light microscopy, as you can see, is the thickened basement membrane without any hypercellularity. And with PAS staining, it is more clear. You can see how thick, okay, the capillary walls are, but there is no hypercellularity. This is the case of membranous glomerulonephritis. Okay. Now, there are conditions where you can have a thick capillary wall with mesangial expansion, but there is little or no hypercellularity. So what are those conditions? Diabetic nephropathy with diffuse sclerosis. Remember, in diabetic nephropathy also you can have in later lesions nodular sclerosis as well, that is called as Kimmel-Stein-Wilson's lesion. That I will come to later. But diabetic nephropathy can also present with diffuse sclerosis, or secondary membranous glomerulonephritis with mesangial immune deposits, or amyloidosis, dense deposit disease, which is nothing but MPGN type 2, or monoclonal immune deposition disease. Okay. So over here, as we can appreciate, that there is a diffuse glomerulosclerosis, as we can see, and there is also some amount of mesangial expansion is there. Okay, so along with this, there is a diffuse diabetic glomerulosclerosis along with some mesangial expansion also. So over here, if you compare this, over here only the capillary walls were thickened, but over here you can also see that diffusely the mesangium is also expanded, as we can see. Okay, apart from the capillaries, the mesangium area is also expanded. So histological image of diffuse diabetic glomerulosclerosis with nephrotic syndrome. Next condition is where you have a focal segmental glomerulosclerosis without any hypercellularity. Okay. Now remember, I am not going to speak in detail about it. What is focal change? What is global change? Okay. What is segmental change? Okay, all these things we have already discussed in details, okay, in the main lecture. So over here we are only going through the changes, okay, that is relevant for your exam purpose. So focal segmental glomerulosclerosis without any hypercellularity seen in conditions of focal segmental glomerulosclerosis, chronic sclerotic phase of focal glomerulonephritis, or hereditary nephritis, that is Alport syndrome, wherein you can see focal segmental glomerulosclerosis without hypercellularity. So focal means only a part, of some glomerulus are being affected, as you can see. It is focal means that, less than 50% of the glomerulus is affected, and segmental means a part of the glomerulus is affected. So focal segmental glomerulosclerosis, you can see over here, the lower part basically of the glomerulus is being affected. A part of the glomerulus is affected, and also less than 50% of the glomeruli, they are affected. Okay, so focal segmental glomerulosclerosis, as we can appreciate over here, segmental sclerosis. Then there are certain conditions under light microscopy, you can see mesangial or endocapillary hypercellularity. So till now we were seeing conditions which were without hypercellularity. Maybe there was capillary thickening, maybe there was mesangial deposition, maybe there was a focal change like that. But over here now we are seeing hypercellularity. So very importantly, the first important condition is acute post-streptococcal glomerulonephritis, also called as a diffuse proliferative glomerulonephritis. Okay. Then we are having MPGN. membranoproliferative glomerulonephritis or mesengoproliferative glomerulonephritis exemplified by IgA nephropathy. Okay, so over here in all these conditions there is hypercellularity. So as you can appreciate, this is the case of acute PSGN or diffuse proliferative glomerulonephritis. So you can see over here there is increased marked hypercellularity, there is an increase in the number of mesangial as well as endothelial cells as well, and lots of inflammatory cells we can see. This is a neutrophil. Okay, we can appreciate, see, can you see such a lot of neutrophils over here, such a lot of inflammatory cells, as we can appreciate some, lymphocytes are there. So increased amount of mesangial cells as well as increased amount of endothelial cells are there in diffuse proliferative glomerulonephritis. So there is hypercellularity, increase in number of cells are there, and you can also see in the past the same has been highlighted. The second basic condition wherein you are seeing this increased hypercellularity is the membranoproliferative pattern. Now, in this particular pattern, there is increased in the number of mesangial cells, also increase in thickening of the capillary walls, plus there is diffuse mesangial hypercellularity, and very importantly in membranoproliferative disorder, you can see that there is a marked lobulation. Okay, they give you a marked lobulated appearance over here, as you can see, along with increase in the number of cells. Okay, so there's an increase in lobulation, diffuse mesangial hypercellularity, and thickening of the capillary walls. So this is the membranoproliferative pattern of glomerulonephritis. And the last condition where there is again increased hypercellularity, especially there's increased mesangial cells. So there's a mesangial enlargement with increase in mesangial matrix and cellularity in IgA nephropathy. This is a mesengoproliferative glomerulonephritis. Okay, this is the PAS, and over here this is the normal light microscopy revealing mesangial proliferation and matrix increase. Now if you see, if you compare the light microscopic features, they are quite overlapping. That is why we need PAS, because PAS is giving us a very clear picture. Okay, that is why we need PAS to evaluate the structures. Next condition.